I think Wound Bed Prep 2024 was very important because we really had to look at many patients with chronic wounds are in resource-limited environments, and that doesn't just include the developing world, but in Ontario we have remote, isolated, Indigenous and Northern communities. The importance of treating the cause and being able to have individuals work in their own community. One of the things is with leg ulcers, compression is certainly the most important thing, but you have to rule out arterial disease. It's also important in diabetic foot ulcers where they may be neurotrophic most commonly, but arterial or mixed disease. The audible handheld Doppler was a way of simplifying the arterial brachial pressure index, which is influenced by calcification. It's influenced, the patient has to be lying flat. They should be flat for 20 minutes. You have to do 4 readings, so you do both feet and you do both arms, and this is a good half-hour exercise. The audible 8 megahertz Doppler is an excellent tool because this can find with gel, and you can even use a very simple gel that may be used for other purposes. The gel can be applied. You can listen to the dorsalis pedis and posterior tibial pulses. If it's monophasic, they need to go to the vascular lab, and it sounds like shh, shh. If it's biphasic, pshh, pshh, or triphasic, pshh, pshh, pshh. Then any biphasic or triphasic wave, the validation study showed that we had equivalence or an ABPI equal or greater than 0.9. It's not influenced by calcification. It can be recorded as an MP3 on your phone. And in that way, patients don't have to leave their community or wait months for a vascular study. For diagnosing infection, we have had NERDs and stonies for years. The NERDs criteria, any 3, we treat topically. And we have silver, we have iodine, and we have non-release dressings that can be used, like containing PHMB or hydrophera blue. For stonies, there are 4 criteria in the side, 3 on the bottom, and temperature being most important. This is where the infrared thermometer, 3 degrees Fahrenheit increased temperature with 2 other stonies criteria, and these patients require systemic treatment. And we have a recent publication to go along with Wound Bed Prep 2024 that covers that extra criteria, and it covers being able to use oral antibiotics instead of IV after the Oviva study in the New England Journal. Keep them in their community, not worry about IV antibiotics. Maybe 20%, even with osteomyelitis, require IV, but maybe for 1 week, not 6 weeks. For plantar pressure redistribution, we have the Dark-Hole boot or anything the patient will wear. Most people don't have access to a contact cast or making the removable cast walker irremovable, or number 2 is removable cast walker. Anything the patient will wear, and with plastisode or porin, we can make a device. Pain is most important to patients than healthcare providers. You need to separate neuropathic pain and nociceptive pain, which is like a toothache, from the burning, stinging, shooting, stabbing. With that criteria, we can decide, is it healable, non-healable, or maintenance. About 2/3 of wounds are healable. Then we can go on to moisture balance versus non-healable or maintenance. It's bacterial reduction, moisture reduction. Yes, we need to document the wound, but we have ways of doing this with cameras now and even measuring depth. Then we look at debridement. An active surgical debridement will make skin substitutes work better. If that's not in your scope of practice, conservative surgical, but even moist interactive debridement with hydrogels or things that have the ability to facilitate debridement require a healable wound. The NERDs and stonies, along with using the therapeutic index for antiseptics, where hydrochloric acid was best for E. coli, Pseudomonas, and Staph aureus, and PHMB was best for methicillin-resistant Staph aureus. So we have things safer to use topically. I think from the point of view of moisture, make sure we're not over or under hydrating. If a wound is not 30% smaller by week 4, it's not going to heal by week 12. Do we need an interprofessional consult? We need doctors, nurses, and allied health working together. Do they need a biopsy? Do they need other investigations? Do they need other specialist consults? Adjunctive therapies comes into the healable wound that's stalled. Maybe as simple as a skin graft. There are skin substitutes. We now have things called a gecko device, which is a myonerve stimulator. Put on the perineal nerve, creates a flux response in the ankle, and that flux response increases local circulation. It's been shown to help venous ulcers that are stalled even at week 4. It certainly helped a number of patients with vascular problems. And the very last thing is to look at the healthcare system. We need to move from knowledge translation to knowledge mobilization, where what we do is within the system. And for example, we borrowed patient navigation from Cancer Care Ontario. We had 48 patients in Waterloo, Wellington with Helen arbuthnothan that weren't healing or were costing the system a lot of money. We then had the wound bed prep 2024 assessment of those patients by an NSWAC nurse. I then met with the patient, a family member, the primary care nurse, and the NSWAC team from Waterloo, Wellington. We did attend a systemic report of each of the criteria in wound bed prep 2024. In the 48 patients, 29% of them actually healed. Some were on home care since 2010. We had 2/3 of them smaller. Over 70% used less dressings and less nursing visits. 80% with the NERDs and stonies, better diagnosis and treatment of infection. And not all of them, including diabetic foot ulcers, had pain, but 74% of them improved pain. And that is published as a follow-up in advances in skin and wound care. And what I've just talked to you about, the knowledge mobilization, knowledge transfer, is the editorial in January, February 2026 advances. And I think using this, we can help patients to have better outcomes, better use of the healthcare system. And we know the simplified 60-second tool for the high-risk diabetic foot can identify high-risk items 1 to 10 and have patients be responsible for following up on this. Blood pressure, which is reasonable in Ontario right now. But the third component of this is really looking at the patient as a whole, as in the wound bed prep paradigm, and I've just outlined. So I think we can do better, we can improve surrogate outcomes, and we can make the healthcare system more efficiency using this paradigm.